Well, hello again. This is Marion Williams again. I'm the ER nurse and flight nurse, and tonight, actually, it's nighttime. We're going to talk about the nervous system, its neurology. So the objectives for this lecture lists the regions of the brain, cerebral perfusion pressure, blood-brain barrier. We're going to talk about neurons, neurotransmitters, sensory pathway, sympathetic nervous system, which I think you know mostly, fight, flight, or freeze response, and spinal cord and some systemic conditions. So let's go to the nervous system. Let's look at it overall. Overall, we have the central nervous or the nervous system and two basic branches. Central nervous system, which is composed of the brain and spinal cord, makes sense, right? That's what keeps us here and awake and alert and oriented and upright, etc. The peripheral nervous system consists of motor and sensory, and that's what you and I have in our extremities, right? Motor, sensory. Also, we have it all over our body. So I know where you may touch me. If you touch me in the head, I can tell you that. Okay, and under that, we have the autonomic nervous system, which breaks up into the two divisions of sympathetic and parasympathetic. The sympathetic nervous system is your fight or flight mechanism, whereas the parasympathetic is your rest or digest. Okay, so here we have the central nervous system, the brain and spinal cord, and then we have the peripheral nervous system, which really is a whole conglomerate of nerves. And no matter where we are in our body, we can feel, sense, etc. And that's what keeps us alive and safe is our peripheral nervous system. All right, the brain weighs about 3 pounds. Isn't that just amazing that all the information you have accumulated throughout your life is in 3 pounds? That is just another miracle. Well, the whole body is a miracle, but some things really stick out, don't they? So if I'm looking at your brain here in your forehead, is your frontal lobe. Your parietal lobe is in between your frontal and your occipital lobe, which is in the back of your head. Your temporal lobe is along the sides and both sides of your head. Okay, we're going to go into those in more detail. Okay, at the bottom, underneath my occipital lobe, I have what looks like a cauliflower kind of thing. And that is called the cerebellum. Okay, the cerebellum is the center for your being able to maintain your balance, etc. So there are four major lobes, like we just discussed. There's two hemispheres. You have one set of that on one side, one set on the other side, and the cerebral cortex is the outside layer. Now, I want to just mention a little bit about the cerebellum. The cerebellum is like a cauliflower looking piece of tissue, and it is in the back and underneath the brain. Looks like a cauliflower, it really does. Very similar. It's responsible for motor control, muscle tone, your equilibrium and balance. And I'm going to just tell you a little story about a patient came in that'll kind of help you remember this. He came into the emergency room like 3 o'clock in the morning, and he said he had a headache. And I thought, this is Mary, and you know my behavior now, what I'm like. I was thinking, it's 3 o'clock in the morning, you have a headache. I'm working and I have a headache. But anyway, of course, I didn't say anything like that. And I triaged him in, was taking him to the back to put him in a bed so the doctor could examine him. And he was walking weirdly. I had to hold on to him. So I put him in a room and the doctor went in to examine him and he came out and he said, Marion, you know what? I think that guy has a cerebellar tumor. So anyway, we sent him down for a CAT scan. And sure enough, that guy had a cerebellar tumor. From then on, I never thought bad about anybody having a headache because he had a real headache. So we called in the oncologist. And so I said, a few days later, I was taking a patient up to the unit and I saw the oncologist. And I said to him, what about that guy who had that bad headache and that cerebellar tumor? How's he progressing? He said, he's going to die. That really took me aback. I thought, he's going to die. And here I thought he just had a simple headache. So it's really important to think of patients. And I did thereafter for the rest of my life. Anyone who has a headache, I'm really concerned about them because I don't want it to be a tumor. And I was so embarrassed and felt so bad that I thought, yeah, I have a headache too. Um, so anyway, the frontal lobe. The frontal lobe here, right in front, is responsible for your personality, your behavior, how you learn, and your voluntary movement. Now, there is a very famous family called the Kennedys. Pardon me. And John F. Kennedy, President John F. Kennedy, had a sister and she had a lot of mental problems. So her father at the time, and this is way back, I don't know, maybe 50s, he thought, okay, I'll know how to change her behavior. I'll have a neurosurgeon take portion of her frontal lobe. So he did just that. So I took away her whole personality, her behavior totally changed, and she was placed in a pardon me, mental asylum at that time. And she wasn't brought out into the public realm. So frontal lobe is very responsible for who you are right now. Okay, the parietal lobes up here process your touch primarily here, does other things as well. It somatosensory means somato out in the body and sensory, the sense that you feel. Like I touch you, you can feel that. That's a somatosensory mechanism. Temporal lobes are on the side, and that makes sense because it has to do with your hearing, has to do with your smelling, and has to do with some speech. So it's your occipital lobe is back here just above your cerebellum. It's responsible, oddly enough, for vision and your visual memories, remembering when you were on the beach in Hawaii or Tahiti, wherever you went. Also, where you are in space and the fact that you can aim and pick up a cup of water. Prefrontal cortex, which is at the very beginning of your frontal lobe, that is the part that probably, I don't know this, I'm just guessing that it is the part that the Kennedy family had removed from that sister of John F. Kennedy who had some mental issues. So if you have in your prefrontal cortex if you have adverse behavior or antisocial behavior. It may be partially due to your prefrontal cortex. Well, that would be none of you, of course. Okay, there are some areas in your temporal area called Broca's and Wernicke's. Broca's motor speech area right there. It's in the frontal lobe rather than mostly on the temporal lobe, and it's so that you can form speech and you can say the words, although it seems like right now I can't. Wernicke's area back here is in the temporal lobe, and it's comprehension and processing of speech. So people who have a stroke sometimes, you may have run into these people. They know what you're saying. They're trying to respond to you, but the words are coming all out funny, or they may not even be words. So this is a problem with the speech areas of the brain. The thalamus takes your data, takes information that goes into your brain, and it processes it, and it kind of sends it where it needs to go in your brain. Hypothalamus is here in your brain, and it is kind of a very important hormone because it releases hormones and it controls your pituitary gland. Now, your pituitary gland has anterior portion and a posterior portion, and each one sends out hormones, mostly at the direction of the hypothalamus. It's kind of like the president of your brain, and it tells the his minions what to do. Amygdala is at the bottom of the ventricles, and I'll talk about ventricles in a second. And it is where our lower behavior comes from, like our anger, our rage. We may be afraid of everything. That's why they call it reptilian behavior, because it's not culturally acceptable behavior, and it just comes naturally from us. Some people are more prone to rage than others. Hippocampus is on the floor of each lateral ventricle, and that is kind of, they think it has to do with memory and your emotional memory. Oh, I remember I was so mad at that guy. That's the kind of thing that it kind of that comes from the floor of the lateral ventricles. The midbrain, also known as the brain stem, attaches to the spinal cord. Now, you and I have been talking about that a little bit with respiratory control, cardiac control. And so it's extremely important in the function, your basic functions of respiratory and heart. From here also comes your cranial nerves, which I'll talk about a little bit later. So your pons is here, your medulla oblongata, which goes directly into your spinal cord. And so that's why it is so important, because if there's ever severing of the cords or severing medulla oblongata this high, you're basically not going to survive. So the pons is between the midbrain medulla oblongata, and it has to do with your breathing. Okay, so the fact that you're even breathing now, you can thank Mr. Pons here. And it also has to do with your dreaming and your rapid eye movement sleep. So medulla oblongata, as I said, it meets the top of the spinal cord. It controls your basic survival skills like heart rate, breathing, and of course, blood pressure. Now, we'll talk about some more of the brain in a minute. The outside of the brain, what keeps your brain from not being injured by somebody touching you on the head or anything like that? Well, first of all, you have your skull. You have that hard bone that protects your brain. Then underneath, you have your linings that surround your brain, just like we had the pericardium around the heart. We have these three layers. The outside layer is called the dura mater. Dura meaning it's durable, okay? It's, I think in Italian, somebody can correct me, it means tough mother. Arachnoid mater is below it, okay? And it is arachnoid. I think spiders and all those kind of creepy crawly things are called arachnoids, right? And because of the arachnoid space where there are blood vessels, I think that's why it was called arachnoid mater. So subarachnoid space just below it is where the blood vessels are. Pia mater is the lining which is closest and attaches basically to the brain. So those are the three different coverings of the brain and spinal cord, and they're called meninges. So if you look at them, you can see that we can have injuries. We can have injuries if it goes through, if your trauma goes through the skull. We can have damage below the dura, above the dura, below the arachnoid mater, and we can have injuries within the skull. Now, it doesn't necessarily have to be a penetrating trauma. It can be, I have hit my head really hard, and my brain that's inside my skull goes forward and backward and maybe forward again. They call it coup, contra coup. And in that case, I can rip those meningeal layers. Some of them I can rip. And so I can cause bleeding. And you can see above the dura mater, here is bleeding. Generally, it's arterial bleeding. Subdural, below the dura. Now, this is above epi, above sub, below the dura. I can also have bleeding. And I'll give you some of the types of patients that you would have with that when I talk about the neurological emergencies. So therefore, you have those three layers. If you look at it from the outside in, the closest layer to your brain is pia mater. That's a P. Then further out is your arachnoid mater. That's an A. And then the outside layer is dura mater. So that makes PAD. So it's patting your brain from the inside out, pia mater, or little mother, I think it means. So we also have something else that cushions our brain. It is the spinal fluid. And the spinal fluid is made in my lateral ventricles, and it bathes my brain tissue and my spinal cord. And so it provides a beautiful protection for them. So we have, I mentioned I talked about a little more ventricles, 4 of them. And you can see here's my ventricles. Okay, I have my lateral ventricles here. Okay, this is looking at it. If I look down at my brain, and here is looking if I cut a hole or cut part of the brain off. So you can see I have my lateral ventricles. Then I have a third ventricle, and then I have a fourth ventricle here. So the cerebral spinal fluid is made in here, and it travels to the third ventricle and then into the fourth ventricle and then down into my spinal cord. But here it goes all through my brain as well. So here's another picture of it. You just need to know that you have lateral ventricles, and that's where CSF is made. And you have a third ventricle. This part right here between my laterals getting the fluid to my third ventricle is called the interventricular foramen. Foramen always meaning opening, interventricular in between. So this is called interventricular foramen. Goes down to my fourth ventricle, and then it goes into my spinal cord. So here is the brain, right? This is obviously somebody who is no longer living, duh, right? And here it shows my lateral ventricles. They look like little butterfly wings, don't they, kind of? Um, and this part in between here, in between my two hemispheres, is called the corpus callosum. And that you should know that what that structure is. So it's a corpus callosum. Now let's talk about that the cerebral spinal fluid or CSF that's in our brain. We also have blood going through our brains, giving our brain oxygen, glucose, and sodium. Remember, I told you at one point that they are needed by the brain tissue and they don't store them. So we keep having to give the brain oxygen, we keep having to give it glucose, and we also need to give it sodium. So cerebral blood flow, the brain is again magical. It's so great. The brain is able to maintain its own blood flow, basically independent of my blood pressure. Okay, it can do that up until a point. There is no absolutes in our body, right? Because remember Starling's law, the heart will try and maintain its stroke volume, cardiac output to a point when it can't anymore, and then the left ventricle starts to dilate. Same thing with our brain. These cerebral blood vessels do what they can to maintain the cerebral perfusion pressure in the brain, the pressure of the blood in the brain, the blood flow, I should say, in the brain. The normal is 60 to 160, differs with different books you read. Now, you and I out in the field don't know exactly what their normal pressure is. But if the cerebral perfusion pressure gets below 50 millimeters of mercury, then the brain is ischemic. It's not getting enough oxygen, not getting enough glucose, and not getting enough sodium. So what we can do, though, is have an idea how well the brain is perfusing with its blood vessels. So something I didn't mention in cardiovascular was the mean arterial pressure, the MAP. Now, when you have your patient on a monitor, the MAP, mean arterial pressure, is calculated for you. And you don't have to figure it out. Not that it's a big deal to figure it out. But the MAP is the mean arterial pressure, which means the basic pressure that is occurring in all your vascular system. Okay, so I want it to be maintained between 60 and 100 millimeters mercury. Again, the only way I can figure that out is by having a systolic and diastolic blood pressure. Your monitors are beautiful, they figure it out for you, but you and I can figure it out on our own. So I'm going to show you how. Take one cardiac cycle, okay? That's systole or contraction of the ventricles and relaxation or diastole. Okay, so let's say it takes 1 second for one heartbeat to contract that heart and relax it and let it fill with blood. Actually, we'll divide that 1 second now into threes. 2/3 of that time, the heart is in resting phase. And 1/3 of that second, it's in systolic or contraction phase. Therefore, I can calculate it. I take my systolic blood pressure, I add twice my diastolic pressure, and then divide by 3. So that's how they came up with that, is because somebody somewhere calculated the amount of time in one heartbeat that systole is taking place and how long diastole is taking place. So diastole, or resting of the heart and the filling time, is twice as long as the contraction. So systolic blood pressure plus 2 times the diastolic divided by 3. So the cerebral perfusion pressure then is your MAP, your overall arterial pressure in your body, minus the intracranial pressure. Now, you and I have pressure that is being maintained in our brain, and that is called intracranial pressure. Its normal is 7 to 15 millimeters. Now, I could measure that if I had a right piece of equipment and stuck it into your actual brain tissue. And we can do that, and we have done it, obviously. So CPP, your cerebral perfusion pressure, equals your MAP minus your ICP. The only thing out of there that you and I can find out in the field or in the ER without specialized equipment is our MAP. Okay, so if my MAP, my mean arterial pressure, goes down, then I know that my cerebral perfusion pressure has gone down. And that could be devastating. And if my intracranial pressure goes up because I have an injury to my brain tissue, then that's bad news. So my cerebral perfusion pressure equals my MAP minus my ICP. Now, I can assume if I have a brain injured patient that his intracranial pressure is going to be elevated. How can I tell? Well, a few things. Number one is his consciousness level. Another thing is his pupils. Are they dilated? Are they fixed? Are they reactive? So that's going to be an important thing. So I can assume some of this stuff by examining my patient, and I do have an actual map. So this my intracranial pressure, my patient isn't damaged or any trauma to his brain, then I can assume it's probably normal. So if his map goes really down and my patient's intracranial pressure, I think is okay, I don't know he has any trauma, then his cerebral perfusion pressure can go down, and that would be bad. So without the proper equipment, I can't get the exact idea what it would be. Okay, so now blood-brain barrier. Because I have blood and brain up here in my head, there is a membrane between them. There are cells between them. So the blood from my blood vessels in my brain don't bathe my brain tissue. But there is a membrane keeping the blood in the blood vessels and keeping my brain tissue in its place. So that is a good thing, because those cells between my blood vessel and my brain are selective in letting things go across. Think of it like you're selective who you let into your house, and your front door is your membrane. So a lot of drugs are past the blood-brain barrier. So one of them that passes it very quickly is alcohol. So if you take, I don't know, say a glass of wine, probably you'll start to feel the effects of it. Maybe you feel a little dizzy. I don't know. I don't drink, so I don't know what it feels like, but I assume you start to feel a little bit dizzy, a little bit lightheaded. That's because alcohol has passed this blood-brain barrier. It's gone out of the blood and into your brain, making you feel that way. So it's very important to know what drugs pass that barrier, which is many of them, but some don't, but most probably do. So when we give a drug, it's going to be very important to know, is it going to affect their cerebral functioning? Okay, now what about the actual tiny little cells in the brain? Now that's an issue. Now we know what a cell of our tissue is. It's kind of round usually, and it's got a bunch of things inside, mitochondria, all kinds of stuff, right? Now, nerve cells look differently from our tissue cells. We have many, many, many neurons, your nerve cells called neurons. It said billions of them, okay? And the brain is such a unique, complicated structure. I can't even imagine being a neurosurgeon. I had one in one of my ACLS classes a little bit ago. And I said to him, just tell me, how many years are you in neurosurgery after medical school? They're in it 7 years, and then they do post-grad work after that. So they're in school, and they probably don't start practicing neurosurgery till their late 30s or early 40s. So they have incredible amount of a study to do, and they still don't know what the brain is all about. So we have nerve cells called neurons, and we have basically three types. We have a neuron going to a neuron, and then we have a neuron coming out of the neuron. So we have an afferent going in, we have the neuron, and then we have a neuron going out, or efferent, meaning exit. That's how I remember it. So we have glial cells, and they're the supporting cells of the brain tissue. Okay, so glial cells, you may have heard of them because sometimes you hear of people with brain cancer that have a gliotype brain cancer. And that is pretty virulent because it is supporting cells. So it's kind of all over that area of the brain. So here is our neuron, which really is composed of the three types of neurons. So we have the afferent neuron bringing some stimulus to the neuron. Now, this neuron here, it has all these little trees, sort of speaking, out of the main neuron here with my nucleus here, and it picks up all kinds of information that it's going to transport. Could pick up sensory, could pick up motor, etc. And it takes that information and it passes it through the axon, which is what this is, and it takes it to, it looks like a bunch of suction cups. That's what I think of it as. And these suction cups take that information and they're holding on to it. And I'll show you another picture what it does with it. Now, these axons may be covered with a white substance called myelin sheath. This myelin sheath, the reason it is there, it's to make that electrical information pass faster down the axon. The Schwann cell, is a supporting mechanism for the myelin sheath. The nodes of Ranvier are these little nodes in between the myelin sheaths along the axon. And then it takes the information to this axon terminal in these little sacs. So what it does, it's taken the information through these dendrites into the axon, which may be covered with myelin sheath, and it takes it to these little sacs. Then there's a space between these little sacs until there's the next neuron with the dendrites. And this is showing this is here. So that information has to cross that synapse or that gap in order to get over to here. And there are certain substances that will transport that information. And I'll give you all the hormones, or most of the hormones, that take that information across that little gap and send it on to the next neuron. Now, there is an action potential, just like there was an action potential of the cardiac cell. There's an action potential, obviously, of the electrical cells in the brain. And it looks a little differently than it does in the heart. And it goes faster and it rests faster. So the sodium fast, then the potassium goes out really fast. So it's has to go really fast because you're thinking, you're moving all the time, and there's millions of these going on. So we have this sending neuron, okay? So it's picked up some sort of sense over here or motor, okay? And it's sending that electricity across here. Let's say you want to move your right arm. Okay, so you're thinking about moving your right arm, and the sensation goes over here, afferent towards, goes down through this neuron into the axon, through the synapse here, into the receiving neuron, and it goes further on and on and on until it gets to where it tells you to please move your arm. Okay, now this here is a blown up version of this. So in here, I have these little sacs carrying neurotransmitters. And neurotransmitters are little chemicals that will take the information across this synapse, this gap, and take it on to the next neuron. One of them is, which you know pretty well by now, is epinephrine. Norepinephrine are neurotransmitters. And so they're going to take the information, take it across a gap, and give it to the next neuron to take, and so on and so forth. So here's your gap again, your synaptic gap. And it transmits here, the terminal transmits that signal, which I just told you. And it comes across here and it is grabbed then by the next neuron. So the fluid, this is fluid actually in here, and it's called the synapse. The space is called the synapse. There is fluid there, and that's how your chemical transmitter, like your epinephrine, gets across to the other side, to the next one. So I mentioned that myelin insulates the axon and speeds electrical conduction, which it does. Okay, now if there's damage to that myelin sheath or that axon, that's a problem. And so that's what happens sometimes in a brain injury. There is damage to neurons in a particular part. That is very devastating, or can be very devastating. So just a couple of definitions here. Nuclei is defined as a group of nerve cells in a brain, whereas ganglia is a group of nerve cells in the periphery. Okay, so nuclei in my brain, a bunch of nerve cells. In my periphery, it's called ganglia. Preganglion are nerve cells that come from the brain and spinal cord and then terminate at a site. So the nerve cells that come from the brain and go to a site, whether it's my hand, my heart, whatever it is, are called preganglion before they get out to the periphery. So pre-periphery, if you will. So sensory neurons or sensory goes towards your central nervous system, and there's afferent. So I sense, and the big thing we always use is I sense a hot stove. Okay, so it sends an afferent stimulus up to the brain. Okay, and then the brain interprets that and it says, oh, yes, Marion, don't put your hand on a hot stove, move it now. So that's what I do. Now I move it. I sense that was a problem, and then it interpreted and sent me a message down away from the brain and said, move it, move your hand. So efferent is motor, sensory is afferent. I sense, it goes to the brain, my brain interprets it and says, Marion, move your hand, and it comes back out or it exits. Interneurons are the connections between sensory and motor. Makes sense, right? So we have effector organs, okay? Now I could have my sensory and motor, but I also have organs that I can't say, heart, please go faster. I can't say smooth muscle. Now it's time for you in my bronchi to constrict. I can't say that. So these effector organs are parts of our body that I have no voluntary control over. So I told you the path of the impulse, so to speak, so far. And the signals received by the dendrite, which I told you, travels along the axon, and the travel is increased by the myelin sheath that makes that electrical impulse travel a lot faster, and then it arrives at the synaptic terminal, and then it jumps that cleft and goes to the target organ, muscle, or gland. Now there's millions of these that are there sending these electrical impulses through to get to the finally reaching the target organs, etc. Okay, so this is what I showed you earlier. There is a mitochondria in the and in the vesicle part here, but you don't really need to know that for today, at least anyway. So here's a vesicle, your synaptic cleft, and then your terminal neuron. Okay, so here are some of the neurotransmitters that take information across. Well, adrenaline, we know it stimulates our sympathetic nervous system, right? Adrenaline and noradrenaline. So it gives our fight or flight, right? If I'm nervous and scared, I'm going to either fight that person or I'm trying to get away from them or I'll freeze, right? Fight, flight, or freeze. Noradrenaline, basically the same, except it has concentration. Norepinephrine helps with my concentration. Dopamine, on the other hand, is for pleasure. It's a transmitter for pleasure. Serotonin is for mood, okay? And you've all heard of serotonin, selective serotonin reuptake inhibitors, SSRIs, and they work on the serotonin in the synaptic cleft. GABA is a calming one, and most of us could use a little bit of that, I suppose. Acetylcholine is more considered a learning one than glutamate memory, and endorphins is euphoria. Now, how do you get endorphins? Well, one way is to exercise. That increases your pleasure, increases your dopamine, increases your serotonin, and increases your endorphins going over that synaptic cleft. So that's one way. Another way is to, opiates do that many times, right? So acetylcholine is one of the most abundant ones. And it is released by both pre and post, and it is pre and post for your parasympathetic, just pre for your sympathetic. Now, there is an enzyme that breaks it down, and any substance that ends in an ASE means that it is an enzyme. Okay, so acetylcholine esterase is an enzyme that breaks down acetylcholine. Norepinephrine, I told you already that you can get epinephrine from IV epinephrine, or you can make it yourself. And you make it yourself from your adrenal medulla in your kidneys, right? So it will increase and send out epinephrine and norepinephrine into your blood vessels. So let's go a little bit more into this. We talked about our central nervous system, which is the brain and spinal cord. It has a relay neuron, so it takes the information and sends it on. Peripheral has the cranial nerves, and I've talked a lot about the vagus nerve, which is cranial nerve number 10. There are 12 of them, gets 10 and 2. And spinal nerves, and we have 31 pairs of those in peripheral nerves. It contains sensory and motor neurons. I gave you the example. I sense a hot stove, takes the information, goes up to the brain interprets it, sends it back down to a motor neuron, and I withdraw my hand. So we mentioned afferent and efferent. So it just takes the information, passes it around the spinal cord here, and goes up into the brain. It interprets it, and then it tells my motor neuron, my motor one now, in the brain. It's called upper motor because it's up here in my brain. And it takes the information back down through my spinal cord and tells me lower motor neuron, okay, lower, below my brain. And it tells me, move your hand, Marion. Okay, so I move my hand. So that's basically how you get a sensory information up to your brain and have the motor effect come out. I want to move my leg. So I have a sensory going up and a motor coming down and my leg moves. Okay, here are your cranial nerves. There's 12 pairs. You don't need to know them for the prep, but you will need to know them in paramedic school. My suggestion is that you start memorizing them now because you're going to need them in paramedic school. So whatever you do now will help you in the end. So the one that I've been talking a lot about is cranial nerve number 10, the vagus nerve. And it goes all over the body. What you and I were mostly talking about was the heart and the lungs. But there are several others. You need to know at least one function of each. Not now, not today or next week, but you will need to know them. So here's a way to easily remember them. And some of them are sensory only, like my nose. I can only smell with it. I can't take away its smell if you wish. So it's only a sensory, has only sensory. Whereas some other things have both, like my facial nerves. My facial nerves, I can sense with it, and it also has motor component as well as sensing it can move, okay? So that's what it means here. So if that helps you, go for it. So the peripheral nervous system now, we have the somatic or voluntary. So I can voluntarily move some of my body, right? That's somatic. I can voluntarily move my body. But there is an autonomic side to my peripheral nervous system, which is the autonomic nervous system. And it's involuntary, right? It happens without my consciously saying, oh, Marion, increase your heart rate. Oh, Marion, reduce your heart rate. Now, how does it do that? So I'm going to tell you some secrets, and these are really cute secrets. Well, not cute, but they're secrets. So I have receptors, little pieces, tiny pieces of tissue in certain areas of my body called sympathetic receptors. There's different kinds. There's alpha and there's beta, and that's all we're going to be concerned about, probably for quite a while. Alpha 1 receptors are vasoconstrictors. Okay, so if my sympathetic nervous system stimulates an alpha receptor, it's going to be in my blood vessels, my peripheral blood vessels, and they're going to constrict. Why would they want to constrict? It's because they want to push more blood from my periphery back up to my heart, lung, brains, and possibly kidneys as well. Okay, we'll skip alpha 2 for now, but we have beta 1 receptors too. How you can remember where beta 1 little pieces of tissue are is in my heart. I have one heart. It's also my kidney cells, but we usually talk about it being in the heart. So therefore, beta 1 receptors are located within my heart. Beta 2 are located usually, mostly, when we talk about mostly because they're located on the lungs. And we have 2 lungs. So that's how you remember where your beta 2 cells are, receptors are. So therefore, let me give you an example. So if I am scared, okay? Let's say there's an earthquake and I'm scared. So it's going to produce a sympathetic nervous system response. How is it going to make my heart increase the rate? It's going to be because I have epinephrine and norepinephrine that are stimulating from my sympathetic receptors, stimulating the beta 1 little pieces of tissue in my heart. It also could stimulate the little pieces of tissue in my 2 lungs, and that will cause my bronchi to relax so I can scream louder, so to speak, okay? It can also stimulate my alpha 1, which are in my peripheral vessels, and that will cause constriction to send more blood up to my heart, lung, and brains because I'm going to now either have to fight, flight, or freeze. And that's how it does it. We told you what it did, but now you know how it does it. It stimulates these little pieces of tissue in different parts of the heart and lung in your vessels. Your parasympathetic also, it has basically not receptors. It has to do with other parts of your autonomic nervous system, and it will block it, and or it will accelerate it. And by the fact that you rest, okay, you go home, you put your feet up, eat bonbons, and you look at your phone. You're resting and you're relaxing, And that's basically what your parasympathetic nervous system does. So if your alpha 1, beta 2 are not being stimulated by epinephrine, then your parasympathetic nervous system will take over primarily. So here's what a stimulation parasympathetic nervous system does. Here's what your stimulation of your sympathetic nervous system does. I told you some of them. I mentioned dilating pupils, relaxing bronchi, increasing heart rate, but there's a few other things it does as well. And then it's going to be the opposite if the parasympathetic system is more prominent than your sympathetic system. So here's your fight or flight or freeze. And if I am scared, like for instance, if my husband comes into the bedroom and I haven't heard him come up the stairs, I freeze. I don't fight or flight, I just freeze. So different people react differently. So here's the sympathetic responses again. And like we said, it's mediated by epinephrine, norepinephrine. But I could also give you a shot of epinephrine, and that would give the same results. So whenever you see alpha or beta, think sympathetic nervous system. So parasympathetic is feed or breathe, rest and digest versus fight, flight, or freeze for the sympathetic. That's how it's referred to. Okay, so here's your parasympathetic response, primarily mediated by the vagus nerve. Remember, I've been talking about the vagus nerve since I started to talk to you in a few classes ago. So your vagus nerve is kind of important. So here's your cranial nerves again, and it gives you more an idea where they come from. And they come from the cranium, they don't come from the spine. Okay, so they originate in your brain. And that's your 12 pairs, okay? So here's some systemic conditions that have to do with your neural health. And one is inflammation and damage. So for instance, I have rheumatoid arthritis, okay? I have osteoarthritis because my fingers here, primarily my index fingers, are deformed. So if I have an inflammatory condition, I can have neurological complications. So for instance, since I have osteomyelitis, you tell me to bend my finger. Well, I can do it, but I can't do it as well as you. So that's how that inflammation from arthritis affects my neural system. Vascular issues. Okay, I've diabetes. I've high blood pressure. What's that do to my blood vessels? It's not only going to do the blood vessels affect my heart, lung, but it will also affect my vascular system in my brain. What about infections? There are certain infections that will cause damage to your brain. One is I can get meningitis. I can get my meninges that cover my brain, they can get infected and inflamed. Meningitis. It can be caused by a virus, it can be caused by bacteria. Bacterial meningitis can be very devastating, especially meningococcal meningitis. I had a girl come in, young girl, I don't know, 14, 15, 16. 6 hours later, she was dead. That's how fast meningococcal meningitis will kill. Metabolic imbalances like kidney or liver disease can cause changes in your brain. Remember I told you that your brain needs sodium to function? Well, your kidneys have a lot to do with the retention and the excretion of sodium. Autoimmune disorders like lupus. I talked to you just briefly, I think, about lupus erythematosus. And it is an autoimmune disease where the body starts to destroy itself. In this case, it can attack your collagenous tissue, but it also can attack your nervous tissue. So it can be cause more damage to your neural system. Nutrition deficiencies. And we've all seen pictures of poor children who aren't getting enough nutrition or the right kind of nutrition, and they will have some brain issues. Rheumatoid arthritis, I just talked about osteoarthritis, but rheumatoid arthritis is very devastating. It causes peripheral neuropathy. That means that I've nerve damage at my periphery. Can happen in my hands, in my feet, and it can happen throughout my nervous system as well as my muscular system. HIV and AIDS can cause cognitive disorders. You've probably heard of HAN, maybe not, HIV-associated neurocognitive disorders. So people that really have HIV can have cognitive disadvantages, like, for instance, you're not able to think appropriately, they can't remember things, they can't concentrate, and it's like a dementia for them, okay? Just as if they did have a dementia. Diabetes. Well, we know what diabetes does to the blood vessels, and it also can cause neuropathy and the periphery, right? People who have had diabetes, maybe their blood vessels are so destroyed that they even lose a limb because of it. Their vascular system is not able to provide enough blood down to their periphery. Cancers, of course, can metastasize to the brain. Kidney disease, we already mentioned the sodium part, pardon me, that can affect the brain function. Liver disease, there's a lot of things that come out of liver disease that go to the brain and cause a liver associated neural damage in the brain, and people aren't able to think and talk. Okay, and then we talked about lupus. So your spinal cord. Now here is a good look at what your spinal cord looks like. Obviously, this isn't someone who is no longer here. So the spinal cord is like a whitish thing, and it's pretty big. Okay, how can I show you so you can actually see it, get my hand in the right position? Um, and it has white matter in it and gray matter. And inside, it's like a butterfly. Remember, the ventricles were like a butterfly looking in the brain? The spinal cord, the gray matter in the spinal cord, if I took a cross section of it, kind of looks like this. So, what parts of the spinal cord? I have C1 through C7, just like I have my spinal cord and I have my vertebrae, right? I have C1 through C7, and my spinal cord is there as well in a passageway. Then I have thoracic vertebrae, and inside them, my spinal cord is there as well. And down to my lumbar L1 through L5, my spinal cord is there and through my lumbar. But then it dissipates further down in my sacrum and coccyx. So I don't have a spinal cord per se, but I have a lot of fibers here called cauda equina. So those of you who are horse people, you will know that their tails, I think, are called caudal or something, cauda, but equina means horse tail, basically. And so they've taken that, and you have a bunch of nerves coming out of your sacrum coccyx. So your spinal cord is protected by these lovely spine, and you can feel the spinous process on your back. It goes all the way down your back, and in behind that is where your spinal cord is. Your true spinal cord ends at L1 and L2, and then we have the cauda equina. So here we have your gray and white matter. So in your spinal cord, here's your gray matter, here's your white matter, and you don't have to remember everything. Just know that your sensing neurons, obviously, your sense, your feel, comes through spinal nerves and goes up into your cord, and then it goes up to your brain from there and comes back down through a motor neuron or motor neurons. So it's going to be obviously more than one. So you feel the sense goes up from your spinal nerve and goes up to your brain, and then gets interprets, and the motor part of it, your response to that sense, comes back down through. Okay, so another word, and this is what makes neuro so complicated, I think. They have a million terms for the same thing. So an ascending tract then is a sensory tract, right? It's going up. I sense it. I tell you that takes that information to my brain, interprets it, and comes out through a motor tract or descending efferent tract. Or the other thing would be an afferent tract, right? Afferent taking the information up, efferent taking it down. So it can end up in a motor response. I can move my hand. So there are spinal nerves. And that's where I said you get your sensory, right? Your sensory comes through your spinal nerves. And you have 31 pairs. Now, when this is important is if I have a spinal cord injury. If I have a spinal cord injury, knowing basically, you're not going to remember all 31 pairs of spinal nerves and where they end up in your body here. I don't know them, and I've been in nursing a fair number of years. But if you just know a few of them, it will help you decide where the damage is at what level of the cord. For instance, if the patient can't use his diaphragm, I know that the damage to his spinal cord, if it's a trauma, is going to be somewhere around C3, 4, or 5. Because remember that little, or you may not have heard this little poem, 3, 4, 5, keep the diaphragm alive. So if you have a problem with C3, 4, and 5, they innervate the diaphragm. So if your diaphragm isn't moving your patient's in respiratory arrest, you know that the damage is at least at C3. So those are the things that you kind of need to remember. We'll give you more things to remember what they call dermatomes by when you come in paramedic school. So we have 8 spinal nerves in the cervical area. Why is that? And I only have 7 C spines, right? Or 7 areas of my spinal cord. Well, it's because I start just above my C1 and I'm here at C8 at my T1. So that's how I get 8 instead of 7. So don't let that throw you off. Then 12 thoracic, I have T12, right? T1 through 12, 5 lumbar, 5 sacral, 1 coccygeal. And the cauda equina is a horse's tail or a bunch of spinal nerves coming from that area. So in summary then, we talked a little bit about the different regions of the brain. We talked about cerebral perfusion pressure, the MAP, the intracranial pressure, blood-brain barrier, neuron types, your afferent, efferent, your synapses. We talked about your hormones that take your information across the synaptic cleft, autonomic nervous system again, and then systemic conditions. We talked about several of them and how they affect the nervous system, and then spinal cord anatomy and physiology. So we will resume later and we will go over neuro emergencies. So have a great rest of the day and we'll talk to you and be with you later. Okay, bye.